formation of blood clots. Now, I said blood thinner earlier, but I want to redact that. So a blood thinner actually thins the blood. These do not thin the blood. The blood is not thinner when you give somebody Coumadin or heparin. We are preventing clots though. So the blood, it's not going to break down the blood clot. It's going to prevent the formation of the clot. So if I have a pulmonary embolism, is the heparin going to break down the embolism? No. The heparin is going to prevent further clot formation while my body breaks down the clot. So here you go. We have some indications. We talked about this before. I did mention in the prior lecture that atrial fibrillation is something we would give an anticoagulant for. So if somebody has atrial fibrillation, they should be on an anticoagulant. Atrial fibrillation, you can think of atrial fibrillation like a whirlpool on the top of your heart. So your atrium is not effectively contracting and getting rid of that blood. The blood is kind of swirling around like a whirlpool. Well, since that blood is staying together, it can clot. When the clot occurs within your heart, it is going to go up to your brain, okay? So atrial fibrillation, we have a concern for stroke because the atrium of your heart is not sufficiently getting rid of the blood. The blood is staying in your atrium, and it will then form a clot. Patients on atrial fibrillation should be on a blood thinner. Some reasons that you can't, but they should be on a blood thinner. Anybody who has an indwelling device, such as a mechanical heart valve that they put in with surgery, those patients would need an anticoagulation. And then after major orthopedic surgery, you would see anticoagulants used to prevent the clotting. Contraindications, if anybody's actively bleeding, we wouldn't want to give that, right? Warfarin or Coumadin, we cannot give in pregnancy. And then when we see that LMWH, that's low molecular weight heparin, this is something like Lovenox or Noxaprin. These are contraindication in patients with an indwelling epidural catheter. So that is within the back, an area to give medication through, and it can actually has an increased risk of an epidural hematoma. Well, what's a hematoma? It's a collection of blood in the epidural space that can lead to paralysis. So some adverse effects here, increased bleeding, that makes sense. We've got some other things, heparin-induced thrombocytopenia. I just want you to hear that word. Heparin-induced thrombocytopenia can be very dangerous. Overall, we're just concerned about bleeding. And our toxicity and management to overdose, it's going to be specific to the drug. Here are all of our drugs, but we know how important anticoagulation is because things like heart attack, stroke, pulmonary embolism can kill you, so we need to approach anticoagulation in different ways. So I'll read to you about the different drugs. Warfarin, Coumadin, which are the same thing, and heparin are going to be our main ones. So our Gabatron is going to be used for thrombus, which is the clot, and the treatment of HIT. HIT is heparin-induced thrombocytopenia. Adverse effect is bleeding. Pradaxa, or dabigatran, is good in prevention of strokes and thrombus in patients with non-valvular AFib, atrial fibrillation. We don't need to monitor. With our heparin and our Coumadin, we do need to monitor our drug values. With Pradaxa, if somebody overdoses, we can give them this drug down at the bottom, Praxabine, and that can actually help. A lot of times patients would come into the ER when I worked at a trauma center and they would have gotten in a car accident, fell and hit their head. Well, if they take blood thinners every day, what are they going to be more likely to have? Bleeding, right? So that trauma could be made even worse because somebody is on an anticoagulant. Some of the newer ones do not have a reversal agent. Heparin and Coumadin do have reversal agents. Pradaxa is one that has a reversal agent, and that is called Praxabind. These names all sound like Greek to me, but fondaparinux inhibits part of that process, the clotting process. So it's going to inhibit factor 5A, 10A. So we can use this to prevent and treat DVTs and PEs. Adverse effects could be bleeding and a decreased platelet count. We know platelets do what? Work for bleeding. We have a black box here again of the potential spinal hematoma, so the blood clot on your spine if somebody has an epidural catheter in. All right, this is one you're going to see. This is what you need to care about. Heparin is an anticoagulant. It's actually a natural anticoagulant obtained for the lungs or intestinal mucosa of pigs, which is very interesting. But it works by turning off the coagulation pathway. So we know that it's a very complicated clotting process. It's going to stop that. It's going to prevent clot formation. Is it going to break down a clot that is already there? It is not going to break down a clot that is already there. Our monitoring for heparin, write this down, our monitoring for heparin is PTT. You may see APTT. PTT is partial thromboplastin time. That is what we need to monitor with heparin. If these patients are hospitalized, we're monitoring it every single day. We may monitor it 4 times a day when we're starting it. So we can give this to prevent clots, but we are not going to give it to break down clots. The dosage of heparin is going to be in units. Here's some information about heparin-induced thrombocytopenia. We know thrombocytopenia is what? Decreased platelets. We have 2 different types here, but basically the heparin can decrease platelets and result in actually a clot. So this is dangerous. I want you to know HIT stands for heparin-induced thrombocytopenia. We have some treatments down at the bottom. Here's a picture of it. You can look at the whole pathway, this cute picture. If somebody has heparin in their body and they get in a car accident or they fall, somewhere where you need to reverse the heparin, you're going to give that drug at the bottom, protamine sulfate. Protamine sulfate is a reversal agent for heparin. You will know if somebody has heparin toxicity because you're going to see evidence of bleeding. So our symptoms up top, we have hematuria. What is hematuria? Blood in urine. Melena, which is blood in the stool. That's our dark tarry stool. Petechiae. Those are these little burst capillaries. You'll see just little spots, kind of pink spots on the skin. Ecchymosis is bruising. So if that occurs, you're going to stop the drug immediately. This is enoxaparin or Lovenox. So you remember me saying LMWH? That is a low molecular weight heparin. We do not need to monitor with this. It's related to heparin, but it requires no monitoring. It typically comes in this pre-filled syringe, and you can give it as a subcutaneous injection. But do we need to monitor with Lovenox? No, we are not monitoring with Lovenox. Rivaroxaban is Xarelto. This is a newer drug. I told you that we've got these newer things. This does not require monitoring. You can see down here, adverse effects are the same with any of our anticoagulants. Somebody may get bruising, they may start peeing blood, they may bleed in places. So with Xarelto, I just want you to know it's newer and it does not require monitoring. Here we go, warfarin or Coumadin. So I told you we have heparin and we have Coumadin. So with warfarin or Coumadin, this works by actually inhibiting vitamin K synthesis by bacteria in the gut. This interacts with a ton of drugs. We do have dietary considerations. These would include vitamin K containing foods. So we talked about that multivitamin, right? So if the multivitamin has vitamin K in it, which it's typically in low doses, you would be concerned about reversing the effects of Coumadin. So a reversal agent for warfarin, sorry, I'll start saying the generic name. Our reversal agent for warfarin is vitamin K. So if somebody is bleeding and they're on Coumadin, we are going to give them vitamin K. Now, if somebody is not bleeding, they're just living their life, and you give them a bunch of vitamin K, what's going to happen? We're going to reverse that drug when we don't want to. So we tell people so vitamin K is in leafy green vegetables. So we're not going to tell somebody to stop eating leafy green vegetables altogether, but just maintain the amount of leafy green vegetables they eat. If they're a health nut vegetarian and that's all they eat, they should stay on that. The warfarin is adjusted to the level in the body. With the warfarin, we monitor the INR. The INR is the internationalized normalized ratio. So we typically see this as PT-INR, so prothrombin time international normalized ratio, so PT-INR. I don't need you to know the values, but just to see. So if your PT-INR, so if your INR is less than 2, which is normal, you're going to be more at risk for clotting, which is fine in people without atrial fibrillation, without high risk factors for clots. So for therapeutic, when somebody has atrial fibrillation, we're probably going to monitor them from 2 to 3.5. If we see that INR above the 3.5, we're concerned for bleeding. So a lower INR, concern for clot, higher INR, concern for bleeding. So what value did we monitor with heparin? PTT. With warfarin, we are monitoring the PT-INR. When somebody is experiencing warfarin toxicity, we want to discontinue the warfarin. It can actually take over 3 days before the liver can make enough clotting factors to reverse the warfarin effect. So sometimes we can taper down slowly. If that INR is too high, we can discontinue the warfarin. There's a whole strategy to do this. Now, if somebody is having the life-threatening bleeding from warfarin, we can give Kcentra, Propylene, but vitamin K is the reversal agent to warfarin. So know that, vitamin